Since the course launched, we've wanted to address the topic of health provider wellness and explicitly discuss the known fact that we health providers get sick too. While exact rates of substance use disorders among health providers is difficult to capture, there's no good evidence that our risk differs from the general public. Unfortunately, while we providers generally understand the need to show compassion and develop empathy with our patients, it does get trickier when the patient is our colleague. For example, if we're having to correct things at work or cover for colleagues who aren't performing in the manner we wish, our thoughts might turn to judgment. Why don't they care about their work the way that I do? Or it might even turn to fear. We're part of the same practice. If they make medical mistakes, how will this affect me? So because of this and other complexities, we actually can be less compassionate and understanding when our colleagues or maybe ourselves get sick. And that makes it even harder to access treatment when we need it. We often are very afraid of what seeking help will mean for our career. If we also experience stigma and judgment from colleagues, it can be an additional barrier to accessing the care we need. So today, the Addiction Treatment Course team is thrilled to have the opportunity to talk with Dr. Scott Teitelbaum, who has spent the better part of his career providing addiction treatment to healthcare professionals. Dr. Teitelbaum works at the University of Florida College of Medicine, where he is professor and vice chair of the Department of Psychiatry and professor in the Department of Pediatrics. Clinically, he is chief of the Division of Addiction Medicine and medical director of the Florida Recovery Center, which specializes in treating health professionals who have developed substance use disorders. Welcome, Dr. Teitelbaum. We're very honored to have you with us.
It's a pleasure to be here. Thank you.
So to get started, we really want to talk about the fact that we providers do get sick too. We know that we're not immune, and we get conditions too that might impact our clinical practice. Please tell us about the range of substance use, mental, and physical problems that you have identified among other healthcare providers that might interfere with someone's ability to practice in healthcare.
Well, there's nothing that I haven't seen, and there's no presentation that I haven't seen. I don't believe. I think over the course of the years, as every week goes by, maybe you get a new presentation, and perhaps maybe with COVID, if I had a new story to tell, it would be drunk on a Zoom call. But over the years, with regard to issues related to mental health and addiction, the illness doesn't discriminate, just like cancer or any other illnesses don't discriminate. So I think that for a long time, there's been this concept and stigma of people with drug and alcohol use disorders and mental health issues as something that people that are very successful and smart are less likely to have, and that's just not the case. So the illness knows no barriers, and often I think one of the most difficult things, especially with healthcare providers, is they're so used to being providers and not used to being patients and allow themselves to being helped, that there's that idea and thinking that if I'm good at what I do and I'm competent at what I do, then I can't be all that bad. So I have seen from methamphetamine and cocaine addiction in physicians, alcohol, marijuana. There's not a substance I haven't seen. And most recently, I can tell you in the treatment center, from having a VP of health affairs at a very well-known institution nationally to having one of the medical students. There's that range. So there are no barriers. I'm going to have a smart, gender, race, level of achievements. There are no barriers to problems related to drug, alcohol, and mental health conditions. And let me say that often accompanying the drug and alcohol related problems, addiction, substance use disorders, call it what you wish. The language seems to change over the years. There are often co-occurring other mental health conditions that sometimes are clearer than others. But, we all have a narrative and a story in our lives. So there's always more than just the person having a problem related to what substance they're using. There's always more. And sometimes that more is the presence of other co-occurring medical or mental health conditions. But everybody has their own narrative and story of how they got there.
The summary is that addiction does not discriminate.
No. And it's not, one of the things here to mandatory rotation for our medical students. And one of the eye-opening things is that it just doesn't. So often when people come in, because a lot of times it is an illness of stigma, and it's an ugly illness. I mean, the behavior that people in active use is not pretty. And one of the things we know in the chronic illness model, and it's been equated to other illnesses like hypertension, asthma, and diabetes, and that is very true. In that there's a behavioral component. All people with those other problems, how they behave and how they live is going to impact their illness. But there's not the quote ugliness of behavior. So I'm an asthmatic, and if I'm wheezing or coughing, I'm probably not going to empty our family bank account or go in and throw things at people and act in a way that is going to offend people. So I think one of the things that in our messaging that's important for messaging in the world is that, yes, it's this illness, and there's plenty of genetics and neurobiology and neuroscience to show that. But there's also the other aspect that it's not a very pretty illness, and the behaviors are often immoral, illegal, and that I think we have to embrace that, because the people that are affected sometimes, despite having an intellectual knowledge that there's a neurobiological basis, it's an illness, or hurt so bad, wives, husbands, children, parents, anybody can increase that list. And so I think that's important to always remember, especially in our messaging.
Well, I think you've led me exactly into the next question, which is, can you summarize some common signs and symptoms that you've seen that have led to providers putting patients at risk?
Yes and no. I mean, people always think of workplace impairment, but they forget that it's the presence of an impairing condition. So let's think of a pilot, for example. We can take away the movie Denzel Washington and Flight, where he flies the plane upside down and stuff. But as a rule, as the fellow that started the Human Interventional Motivational Study, which is the pilot's program, said, Scott, we're not going to wait for the plane to crash. So there's the things at work we can see in healthcare professionals: bad charting, irritability, tardiness, a change in behavior, a disheveled look, and the list goes on. Missing in action, not responding appropriately, missing shifts, all those kind of things. But that is not the most common way that I see people. It happens, there's respiratory arrest. This is my world. As recently as yesterday, there was a nurse found in the bathroom with a needle in her arm. That's dramatic. That's not usually the case. More commonly is perhaps somebody gets a DUI, and that particular state flags that person, says, well, we want you to work with your physician's health program. And then they go and somebody does some labs and recognizes, hey, the person is still drinking. And then you look, and then you further investigate, and there's a ton of problems at home, in their personal life, perhaps some other issues, mental health conditions. And when you look hard and you do this long enough, you'll find that most people will end up saying that they were less than their best self performing their job. But it's not always that behavior that brings them to attention. So impairment at work I'd have to look at the numbers, but it's probably somewhere between 25 and 30% of what I see. Sometimes it's diversion. Somebody gets caught with, they look at the Pyxis and they see diversion, and there's no workplace impairment, but they see there's evidence of diversion. So sometimes it's workplace behavior, but sometimes it's not. And one of the things that people do forget in the treatment of healthcare professionals is that we don't want to, everybody talks about the impaired physician or the impaired healthcare professional. Impairment is what you're trying to prevent. That's what you don't want. So you don't want to wait until, there's a patient-related injury before you do something. So I do see all those things: poor charting, sloppy charting, tardiness, change in attitude, irritability, missing shifts, a higher amount of call-ins. And then depending on the substance, for example, if somebody with an alcohol use disorder is much more likely to be missing, Mondays or the day after a long holiday weekend, where somebody with an opiate use disorder that's diverting opiates, they're there a lot, because if they're diverting, they kind of want to be there in the beginning, at the end of their shift. So you have to, when you do this long enough, what is the substance? What does that look like? But it's not always workplace impairment. And one of the great messages, which I really want to have people take home, and we always do when we educate our faculty at the University of Florida and incoming residents or nurses, is that the idea of intervening on a colleague or doing something, and the idea is always, oh, we don't want to do that because we're going to ruin their career, and we're a little bit worried, and we don't want them to be impacted in their career. Nobody ever thinks of, maybe we'll save their life. And there are no other problems where people would act that way. If you thought somebody had COVID, or you thought somebody had cancer or looked really sick, you'd say, hey, you really don't look good. Not so with this illness. So there seems to be this, what we call a conspiracy of silence, and that people are almost afraid to intervene because of a fear that the person's life and career is going to be ruined, as opposed that it might be saved.
What I hear you saying is, if you know there's a problem, don't wait until they have impairment at work. Ask them if they need help, or
sometimes, I think now that's also tricky because the afflicted individual is the last person to recognize it. Mm-hmm. And often denial and dishonesty, and mostly because of shame and fear, people don't want to say, oh, I need help. Oh, no, they'll have, especially healthcare professionals, have the most clever excuses, clever, well thought out excuses. So I think expressing concerns, but sometimes intervention and saves lives, and gratitude may come later. I can tell you stories about two dear friends of my own at the University of Florida. Of course, I wouldn't give away confidentiality, where I had to intervene. And they were angry with me for a period of time, and not so today. And I think so often early on, there needs to be kind of this sense that you're doing the right thing with good motives. But I want to repeat that we wouldn't look at any other illness. We wouldn't hesitate to say, you don't look good, you look pale, you look tired. But I would always try initially, unequivocally, to sit down with the individual and express concern in a loving, kind, but honest way of what you see. Sometimes you need more.
So, Dr. Teitelbaum, you've talked a couple of times about health provider assistance programs. Can you tell our learners what that means?
Yes. Well, every state, the joke is, if you've seen one professional healthcare program, you've seen one professional healthcare program. Every state has different programs. In Florida, for example, there's the what they call the Professional Resource Network, which is all healthcare licensees except for nurses, which is the intervention project for nurses. So every state, some states have a pharmacy, veterinarian, and dentist program. Some states, like in South Carolina, they have all of them together. So every state is different. So that's one thing to know. But they're in general, and then there are also different states, they're funded by different people. Is it the Board of Medicine? Is it the Medical Society? Those are some differences. But at the end of the day, what they all share in common, they're a safe harbor. That's the goal, a safe harbor. So the number one goal is that the protection of public health. So the person's not, they're involved, and so you're protecting the public, but at the same time, you're providing a safe haven for the practitioner, that they're not, you don't have a public record, everybody doesn't know, and that they advocate, they're monitored. And so those programs act as kind of a safe haven and a place that both makes available evaluations and or treatment, and then monitors the individual. Most, not all of the professional health programs do not do their own evaluations, nor do they don't do their own treatment. They get the referrals, they set them out to a list of approved evaluators and or treaters, and that's critical in that you need a choice. So there's not the conflict of interest or the appearance of a conflict of interest. So a choice of evaluators that are approved by that professional health program, that PHP, and that a different choice, that maybe the person that evaluates treats them, and maybe not, another choice. So that there's not that conflict of interest. But most of these programs do not do their own evaluations and or own treatment. They facilitate involvement of other people that do this for a living. And it is different than the treatment and evaluation of a healthcare professional is not the same as treating any other person with a substance use disorder. For example, it's very different for me. Giving just a simple example, I was talking with my neuropsychologist today about cognitive testing on a radiologist who had some visual spatial difficulties. That's important in reading an x-ray. At least if you're reading my x-ray, I'd like you to be able to have intact visual spatial. Might not be as important perhaps for a psychiatrist. Okay. And I could make fun of maybe what I do and other people, but there's certain levels of deficits and stuff, and certain things to think about with regard to what somebody does for a living, what are going to be the parameters of returning to work. Do they work alone? Do they not return to work alone? Can they be on opiate agonists? Do they need opiate blockade? There's a lot of different things and unique set of things to consider in the evaluation and treatment of a healthcare professional that doesn't exist in other people.
Dr. Teitelbaum, I know you to be open about your own personal journey. What was your experience seeking help?
So my experience personally was not very different from what I see sometimes professionally. And I always remind myself, this is what I do. So I separate what I do for a living versus my own story. I think that's always important for me because everybody has their own story and narrative. But I was a practicing pediatrician in your state, in Connecticut, had a very successful practice. And so in my world and my own denial, if I was good at what I did, I couldn't be very bad in my own, drinking. And my primarily was marijuana, alcohol, and cocaine. And interestingly, just when you look at substances, the cocaine, the slope down was much greater. So that's what kind of got me in trouble. When I look back, I probably had a long-standing marijuana problem. But my family, when I look back as a husband, as a father, and as a son, I was not what I could have been. But it wasn't until that actually was my wife that said I needed help at the time. And it took me a couple of treatments. And I would be a good example. I went to treatment and I came back and underestimated what it was going to take to get and stay well. And I finally did get well. I went to treatment twice. I like to tell people they liked me so much they invited me back the second time to visit again. And August 22nd of 1996. And then I was a primary care pediatrician, and some people that knew me thought that perhaps I could have some ability to do this for a living. I retrained in child psychiatry and addiction, and I've been at the University of Florida now 24 years.
I'm particularly curious about how you ultimately found help.
As I said, the first go around, when my wife lovingly pointed out to me that my behavior might have been a bit aberrant, and she thought I needed help. I was a little bit, indignant, like, what are you talking about? And I first did get some treatment and volunteered for the Physician's Health Program. But I was an example of minimizing how bad. I didn't think I was as bad. I was good at what I did, so couldn't be that bad. So I did get some help, and really it was my family. It wasn't a work-related thing. My wife was worried about my smoking and marijuana. Whenever I did cocaine, she was concerned about me. And
gotcha. So your wife talked to you about how she was concerned, but it also sounds like at the time you did have a professional health program as well.
Yes. Yeah. I wouldn't be, for me and for a lot, looking back, if it wasn't, it was great motivation early on. Drug testing was good. It was a good deterrent. And it was a good way early on to maybe if I had an insidious thought. And I was involved in a professional health program. And it was for a significant amount of years. I'm not today. I'm not worried if somebody asks me for a blood, hair, or urine. That's one of the beauties of being in recovery. I'm not really worried about what would be in it. As long as my chocolate chip cookies don't show up, I'm okay.
Once people go through these programs, I know many people do and can recover. Can you talk about your own recovery and the impacts on you personally and professionally?
Yeah, I can. I'll try to do it without getting too teary. It'll be 25 years on August 22nd. And if my kids were on the call, my older children, they would tell you that the only thing that really matters that I gave them was my recovery. I was very blessed that when my mother and father died, which is about 17 years ago, I was able to, help and be a source of help in their own medical illnesses. I was the only physician in the family. And then I will never forget sitting at a diner in Elizabeth, New Jersey on the way to Florida. And my father, who was a simple man and owned a furniture store, looked at me and said, it was nice to have my son back. So my own personal life with respect to my relationship with my own children, and maybe someday they'll watch this, my three older kids. And my little kids are 10 and 7, and I'm preparing, because they're going to have a talk. They haven't known that aspect of my life, and they will. So my personal life, it hasn't been perfect, and my kids have given me permission to share. I had all three of my older kids had struggles: bone marrow transplant, diabetes, some mental health issues, and they've all been very resilient. And I'd like to think I've been a good example of resiliency. So personally, I've been very blessed, and professionally, I've been fortunate. I did lose a license. It took me some time to get back. I did, and then I retrained, and
What I hear you say, though, is that you see a lot of recovery and that your own personal journey has been one of recovery. And I imagine that when somebody is sick and just entering treatment, they can feel like, where am I going to go from here? But you have a drawer full of notes and letters of
yes.
people who have been restored and entered into recovery. There are a lot more of us in recovery than we might think when we're kind of at our worst, but that there is hope. Thank you very much.
Thank you, and it's a privilege and honor to be asked. So thank you.